辛苦。可是它是8:01，现在是9点。So the first specimen that we've seen before, it's a 77-year-old female. So she had the bilateral ureteroscope examination with bilateral renal pelvis washing cytology. So the last time that we see this case is that we feel that it is a low-grade urothelial carcinoma, and the biopsy has confirmed that it is a low-grade urothelial carcinoma. So because it's not so common, and these can usually only be diagnosed with the washing cytology, because with the washing cytology, we will have these larger papillary fragments with fiber vascular core. So when you look at these larger fragments, if it is a usual benign urothelial fragment, you would expect to see some umbrella cell at the cervix, which is characterized by more abundant cytoplasm, lower NC ratio, and enlarged nucleus, such as these. So these are umbrella cells. But in these fragments, it's very rare that you can see the umbrella cell. Additionally, for those cells who falling off from these cellular fragments, they all have these really monotonous appearance. The NC ratio is a little bit higher, but there is lack of hyperchromasia or coarse nuclear chromatin pattern. Usually the nuclear is very smooth, the nuclear membrane is very smooth, and this type of cell is throughout the entire specimen. So we have these atypical urothelial cells without characteristic feature of high-grade urothelial carcinoma, which is hyperchromasia and coarse chromatin, but the cell was very abundant as very monotonous, suggests that it is a tumor. And then we have a nice architectural pattern of a large fragment of papilla. So this is consistent with a low-grade urothelial neoplasm. Okay, so it is not so common that we can make diagnosis of low-grade urothelial carcinoma in cytology, in urine cytology, but this is a good, very classic case of a low-grade urothelial neoplasm. Maybe we should put it for the teaching slide. Thank you. So the next specimen is a pleura effusion specimen. So on low power field, you can already see there are a lot of cells in cluster, and some of them were loosely cohesive. So it seems to be abnormal. We don't see the usual normal component in the pleura effusion. When we go to higher power, the cell does show high-grade atypia. So the nuclear chromatin pattern is vesicular, and we do see prominent nucleolus. And the cells are very pleomorphic, so each cell looks a little bit different. Additionally, we can observe some intracytoplasmic mucin. So because we've seen the mucin, we know that this is likely not a primary lung adenocarcinoma, because it doesn't look like a lung adeno. And for the usual lung adeno, there won't be mucin in the cytoplasm. So the patient is had an image study that there is a large, like around 10 centimeter pancreatic mass, so it is not operatable. And so the patient was suspected to have a pancreatic cancer. So this is compatible with metastatic pancreas adenocarcinoma above the diaphragm to the pleural cavity. So So the next specimen is a CSF specimen. So the patient do have a past history of lung adenocarcinoma. So for the CSF specimen, we expect to see very low cellularity. So basically, we do not see a lot of cells. This is a cytospin preparation, so we do see a contour of a circle, and there were some cells around this contour. The cell is a little bit not well preserved, but we do see an epithelial cell here. And then the screener do a good job by identify more well-preserved cells. So this is a relatively big cells because this is 40x, and if you see the arrow, it is bigger than the arrow. The cell is eccentric with vesicular chromatin and a distinct nucleoli. So this is consistent with metastatic adenocarcinoma. There were second cells also have a similar appearance, eccentric, prominent nucleolus. So this is also metastatic adenocarcinoma. So for the CSF specimen, history is very important. If the patient had any history, particularly for lung or breast cancer, and then if the patient do have and the clinical do suspicious for CNS involvement, we need to search for these atypical cells, sometimes very scant. Here we only have the necrotic cell, so we have individual cell necrosis, the background cellular debris. These cells a little bit difficult to make definite diagnosis because it's degenerated and the cytoplasm show bubbly, so these can be degenerated cancer cell or histiocytes. So we have two well-preserved cells for us to make diagnosis, so this is positive for metastasis. So the next specimen is also from the CSF specimen. So the patient acquired this specimen when they do a VP shunt, which is peritoneal ventricular shunt. It's usually performed for patient with a high pressure, intracranial pressure. And for this patient, she also had lung cancer. So the high intracranial pressure is likely resulting from metastasis. So because the specimen was obtained during the procedure, this is the brain parenchyma. Because when we do the VP shunt, we need to insert the catheter through the brain cortex into the ventricle and drain the shunt outside of cranial, but underneath the subcutaneous all the way to the peritoneum. So you will have some fragments of brain tissue. So this is the fragment of brain tissue. And then we have the tumor cells, which is much more plain looking than the prior case, but this is usually the case for metastasis. They look relatively like a very smooth border and low NC ratio, but it is big. So these two guys are all metastatic adenocarcinoma. And here we have some more. So you can imagine that because there are more tumor cells, so it is likely to cause the obstruction of the ventricular floor, and then induce the increased intracranial pressure. So the patient would need a VP shunt. Okay, so we have more tumor cells in this case. Then we have a peritoneal washing cytology specimen from a 51-year-old female. So because it's a peritoneal washing, we expect to see some larger flattened fragments of mesothelial cells. So these looks like a mesothelial cell. In the background, we do have a lot of inflammation. So for this case, We also have these more three-dimensional cluster in a glandular arrangement in the background. So this is different from the flattened mesothelial cells that we see. It's usually maintain a honeycombing pattern. For this one, it's three-dimensional, and if you go to higher power, we can appreciate the nuclear atypia with prominent nucleolus here and there. The cytoplasm is somewhat more bubbly, so this is consistent with the peritonean involvement of adenocarcinoma. So likely from ovarian cancer. So the next one is EUS guided aspirations by specimen from the pancreas. So in this specimen, the cellularity is actually not very high. So we don't have a lot of normal element for the comparison. So we do not see a lot of mucosa, intestinal mucosa, and we also do not see the normal pancreatic elements such as acinar cells. In this specimen, first of all, you can see that we do have some cells with sort of like spindling, but like what I said yesterday, this is actually a columnar cell arrangement. So if you go to here, this is columnar epithelium with prominent pseudostratification, palisading pseudostratification here as well, which means the nuclear is not single layer, it's multiple layer. Usually for the columnar cell with this type of feature is when they develop dysplasia. And they have increased like a proliferation. So in the cell space, they were squeezed with a lot of cells. And additionally, for these cells, the nuclear feature is not normal. We have this very weird crescent shape of the nucleoli here. And most of the cells do have some smaller nucleoli. And the chromatin pattern is vesicular. So this is adenocarcinoma. Okay, so it may not to be very apparent at the first glance, but this is a good example of adenocarcinoma with intestinal type of differentiation. So these cells are scanned, but still we can see in the background again. So these is tall columnar cell. This type of cell is not normal in the usual pancreatic aspirations, which means that these are not the normal component that we will see. Additionally, here again you see pleomorphism, and so you can appreciate that the size of the cell is very different from each other. So this is adenocarcinoma with intestinal type of differentiation. So we call this adenocarcinoma. Finally, we have a couple pap smear. So the first smear is coming from a relatively young female. She is 58. Yeah, but maybe still young. So we see a lot of superficial cells. In this specimen, I think we do not see good example of endocervical cells, but this needs to be double checked. And in this specimen, there is only one cluster of squamous epithelium. One of intermediate cells seems to have a very vague coilosity change. The other superficial seems to be more hyperchromatic, but there is only one of these cell cluster. And because of lack of endocervical cells, which means that the patient can be under sampling because there's no transitional zone. So I guess when we see this cluster, this is okay that that we should still call it ascus because of the sample seems to be all exocervix and it is not adequately sampled the transitional zone, and we do see like a vague coilocytic cells here. So I guess this case is good for ascus. And for more definite low CO case, we will usually expect to see much more. So here we have a cluster of cells with definite hyperchromasia. You can compare the chromatin pattern with the adjacent normal intermediate cell. So this is definitely hyperchromatic. And we do have some superficial cell and the intermediate cell with hyperchromasia. The NC ratio is not particularly high. And here you do have a vague coilocytic cell. So along the smearing direction, you can actually find a couple example of these typical squamous cells. So this is a good case for a low CO. Because the coilocyte is not very prominent, we would just call this CIN1. Otherwise, somebody would criticize us that why we don't have CIN1 without coilocyte. It's very stupid. But, finally, this is a 105-year-old female. Old lady present with postmenopausal bleeding, and then she received a pap smear. So she's even older than my grandmother. And so in this specimen, we do see a lot of O blood as compatible with the clinical impression of the postmenopausal bleeding. And in the background, we have some atypical cells in a cluster with a glandular feature. So the chromatin pattern is vesicular. It's a little bit three-dimensional. So I think this is qualified for AGC favor neoplasia because the cell do have more than usual type of atypia, such as this. So the cell is not rounded, it's like angulated and a little bit polymorphism, but we do not see very prominent nucleola. So although I really want to call this adenocarcinoma, but I think that based on the cytology, it's not there yet. So I'm willing to call this AGC favor neoplasm. So this is a good case that we can see these glandular cells in our smear. So that's for all the case today. Thank you.